I'm looking forward to today's talk. So welcome to the GHAPP MASLD Community Network. Today we have a compelling talk. My name is Robin Soto. I'm a nurse practitioner at UC San Diego Health, and I work in general hepatology in the ambulatory space. Here's our QR to register for this meeting. So go ahead and take that so that you can register and we can get started. I'll leave it up for a couple of seconds. Okay, so today we're going to talk about MASLD and MET-ALD and the confluence and the sort of nuance of what those two entities mean in our world of liver disease. So we're going to use a case presentation today. We're going to talk about Ashley, she's a 52-year-old woman. She was referred to your service because on her imaging there was hyperechoic liver or potentially steatosis on imaging. And so she was referred to us by her primary, and also there was some evidence of an enlarged liver. She's 52. Female, and her BMI is elevated at 29.4. So her history, she does have polycystic ovarian syndrome. She has hypertension, hyperlipidemia. Her physical exam is unremarkable. She's on medications for hypertension and hyperlipidemia. She's also taking a multivitamin, and she's on milk thistle because her primary care told her it would be good for her liver. She endorses or tells you that she averages about 2 glasses of wine in a day. So first glance gestalt on this patient, it's got to tell you a little bit of that there must be fatty liver involved, right? We're looking at some of the metabolic risk factors and just generally a good description of what might be MASLD or MASH. So we also have some other information. We've got our vitals, so not ideal on the blood pressure. Like I said, her BMI is elevated. AST, ALT, slight elevations if we're using 20 as our top of normal for females. Our alk phos is elevated also. T-billy platelets are good, and our triglycerides are above 150. So we do have fibrosis information on Ashley, and Ashley's FibroScan puts her at the 11.4 kilopascal level. And so that puts her squarely into a significant fibrosis level. So in some disease entities would call it F3. There's a little bit of a range, but certainly there is some significant fibrosis. So we can assume that there is some damage related to whatever's going on in her liver. Her CAP score is also elevated, and so she has some significant steatosis. So obviously there's some fat in the liver that could be definitely impacting her. So this is where we get into kind of classifying and talking about the umbrella disease now known as steatotic liver disease. So this is sort of our catch-all when we're talking about fatty liver or steatotic liver disease. It includes all of these entities. So certainly on the left side, we're clear with the metabolic dysfunction associated steatotic liver disease, mouthful, MASLD, and then the more inflammatory entity, which is the MASH. In the middle is where we're going to find some distinctions. So as we know, we have a lot of people with MASLD or MASH. We know just by looking at their history and their presentation in our minds that yes, that likely risk here is pretty high, that we're dealing with that. But we also must remember that these people who may have MASLD may also have some alcoholic liver disease or some alcohol use disorder. And so how do we characterize that, and how do we decide where MASLD and MASH stop and MET-ALD or metabolic dysfunction associated steatotic liver disease and alcoholic liver disease, which we'll henceforth say MET-ALD, where that distinction happens. And so I want you to look at the bars underneath the MET-ALD continuum there. And what they're indicating is the first number on the top is the weekly alcohol intake in grams for females, and on the right is the weekly alcohol intake for males in sort of the normal range, or where MASLD would be predominant. Now, what's hard for me is figuring out what alcohol in grams means. So alcohol in grams means, to me, these numbers would mean if we're at the, if we're talking about 140 to 210 grams for a woman, we're talking about 1 to 1.5 drinks. When we're getting up to the high numbers like 350 and 420, we're talking more like 15 to 25 drinks. So again, that the range is big, but for me, it's easier to sort of quantify in standard drinks, which we'll talk about in a minute. So basically, this is to show us that if we're heavy above what is considered not standard drinking or non-risk drinking, for females, it's about a drink a day, and for male, it's about 2 drinks a day. And so if we're leaning on the right side of the continuum, we're talking about alcoholic liver disease impacting this patient as well as the fatty liver disease. And certainly there are plenty of patients who suffer from alcoholic liver disease who don't have MASH. So there's certainly that entity on its own. And then we have some more unusual presentations. There are some monogenic genetic predispositions and diseases that can put you in a fatty liver situation. And there's also cryptogenic steatotic liver disease, where we actually don't figure out the etiology. So there's a big range there. So this is an important slide, and I like to, I like to bring to your attention on this, that when we're talking about a standard drink, this is how they're supposed to be measured in the US, and it actually varies by country around the world. So when we're looking at a beer, this standard drink assumes that your beer is 5% alcohol and that your pour is 12 ounces. Well, anybody who drinks beer knows that IPAs are huge, and those are definitely most of the time above a 5% alcohol content. And the actual glass itself is more like a 16-ounce drink. So when we're measuring drinks or trying to quantify drinks when we're talking to patients, I think most of us probably have to reduce what we actually think is a normal beer, because we're definitely over pouring if you're basing it on these guidelines. Same with wine. You've got a 5 fluid ounces of wine at 12% alcohol. 5 fluid ounces is not a full wine glass, and it's not even a big wine glass. So again, the quantification here becomes important, and we'll talk about more why, but getting a real sense of what your patient is ingesting isn't always that easy, right? And then finally at the end, we've got 40 proof, we've got your shot. Depends on where you go, but I think that, shots usually can be anywhere between 1.5 and 2 ounces. So again, that quantification matters. And when you're assessing and taking a history, our patient Ashley told us she was drinking about 2 glasses of wine a day. You wonder if she really means two 5 fluid ounce glasses of wine a day. So why does this matter? Well, we're basically bringing in 2 pathologic entities into your liver, and when this happens, they tend to work synergistically. They make more problems by differing mechanisms. So we know that our MASLD or NAFLD risk factors include the insulin resistance, diabetes, prediabetes, obesity, your diet, if you're ingesting a lot of highly processed or high fructose corn syrup foods, your lifestyle, if you're not moving, and then also where you carry your fat. If you carry visceral fat, your risk goes up. And then there are some genetically susceptible diseases, as well as epigenetic factors. And so mostly we're seeing from this NAFLD piece, the impaired lipid handling. Those hepatocytes just can't absorb and work with the lipid globules like they would without this impairment. There's oxidative stress and essentially cell death. And then also there's a completely different response to the alcohol piece. And so again, it's causing different problems in different cells in different functions of the liver. So again, the combination certainly makes your risk of progression and makes your risk of the disease being worse much higher. So this is, again, what I'm trying to show is that observational studies show that patients with early MET-ALD and alcoholic liver disease have more than 3 times the risk of developing decompensated cirrhosis compared to the patients on the left side with the MASH only. And these numbers highlight that patients with history of alcohol misuse not only have the greatest need for treatment, but also benefit from treatment the most. So think about that progression. So on your left side, you've got your fibrosis progression in the time frame, and you see that the 5-year risk for patients who are already cirrhotic with MASLD is 5 to 15%, and you go all the way over to solely alcoholic liver disease, and we're looking at a 15 to 50% risk of decompensation. So hugely matters if we're dealing with both or one or the other. So again, thinking about risk of progression and need for treatment on more than one axis becomes important. So this is an interesting study Stouffer did, and basically, the reality is, and I'll speak for myself, the 2 things I probably underestimate most when I'm asked are my weight and my alcohol consumption, maybe my age too. But anyway, so my weight and my alcohol consumption, honestly, I've not weighed the weight that's on my driver's license since I was 16 when I got my driver's license. And usually if you're asking me to actually remember how many drinks I have at a sitting, I may not remember, was it 2, was it 1, how many was it? So again, the idea that we can get good information from self-report alone is a risky proposition, okay? And so what this study was trying to prove is that we do actually need biomarkers that can help objectify the results. And so this was done in Europe, and it's an interesting study. So they compared patients who self-reported to patients who had actual biomarker measurements. And so what they did was they had patients who were considered fatty liver disease alone, and then there were patients who were considered fatty liver and alcoholic liver disease. And then they had the self-report versus the actual biomarker. And this was an ethyl glucuronide sample, which is found, it's a metabolite of alcohol found in hair and urine samples. And so very useful tool in objectifying kind of alcohol use. And so what was interesting in the results, and this graph isn't great at portraying this, but what we're talking about on the left when we get to these numbers is that almost 29% of the NAFLD alone patients had excessive alcohol consumption based on their biomarker. And 25 of the ones that may have had some combination thereof or weren't solely expected not to have any alcohol. So hugely telling here, right? We've got 29, almost 30% of patients who say they don't drink anything having excessive alcohol consumption. So whether it's, understood or just the chronicity of under reporting, hard to say. And also this measure was quite useful. Its area under the curve really shows the diagnostic performance of the 3 different methods in that hair piece. The hair sample was almost perfect in being specific and select, what am I trying to say? Specific and sensitive, sorry, for alcohol. Urine tests didn't really fare better than the audit C. And by the way, this was a European study, so I'm not sure in your centers if you're using any of this hair sample, but it's an interesting proposition. All right, so, the gaps here in assessment of MET-ALD. So a couple of things we want to think about here. So most of us know pretty well what we're talking about on the 9 things or the major things that we see in metabolic dysfunction that lead us to a MASLD diagnosis. And you can see here they're listed, but, elevated BMI, prediabetes or diabetes, elevated over normal blood pressure or on antihypertensive, triglycerides over 150 or on lipid lowering medicines. And so those are required for a diagnosis of MASLD. But what we have to think in this aspect is in Ashley's case, and we'll go back to Ashley in a second, her reported medications and risk factors were isolated hypertension and hypertriglyceridemia. And so if we make the diagnosis of MASLD without having the accurate amount of alcohol ingestion, we may not be making the right diagnosis. And so there are gaps in sort of this assessment way we assess. And what we'll also get into in a minute is how actual alcohol intake can influence these risk factors. And so obviously biomarkers can be more objective, and it can take the issue of self-recall or self-report off the table. We do use PEth tests often, and it is telling. I think it's probably the most practice-changing thing I've ever seen since we've started practice. Is it's very much it can tell you a lot about how you're communicating with your patient, maybe how you're asking your alcohol questions to get the kind of answers that you're expecting, and then actually having sort of an objective measure to confirm or disconfirm, right? And so moving back to Ashley. So we did, in fact, do a PEth on Ashley, and she, in fact, has moderate to heavy alcohol consumption. So all of a sudden, this case doesn't seem quite as straightforward. Again, we assumed that Ashley was telling us about the 2 glasses of wine, that would fit pretty closely in the standard drinks per woman at 20 grams per day, would 1 or 1.5 standard drinks a day. But obviously, for whatever reason, severe underestimation of what we're dealing with, and so that sort of changes everything that we look at. And so the PEth has been well reviewed and is found to be active and effective in populations across socioeconomic lines and different patient characteristic lines. So it is a very valid tool and something we really have to consider in the workup of patients. And so again, so this was just the review that sort of brought PEth into our realm of work. And it basically, what's great about it is it can measure alcohol consumption over the last 4 weeks. So that can be telling in so many ways. If it's just very, very elevated, then we know that we do probably have an alcohol use disorder that we need to address. And had we not checked, we may not have addressed it at all, because we would have been focusing on the MASLD piece of why we think they are having liver issues. And again, it's also a great confirmatory test for abstinence, meaning it will also show that no alcohol in this system for over 4 weeks. So again, useful in the assessment of abstinence and of excessive drinking. And this is just to show that there is no significant variability between by sex and BMI, and that can be important again, right? If we're dealing with MASLD patients, most of them are going to be overweight. And so it's good to know that when we're doing these tests, we're going to be able to use the data and feel confident in it. And so this is an interesting study. So this basically was sort of trying to answer that question. So this was a study done by Diaz, and they basically enrolled patients with obesity or excess weight. And they wanted to see how many of those patients did not have solely MASLD. They wanted to see if there was a MET-ALD built in. And so what ended up happening is these patients had to have some alcohol consumption. If they said no, none, and they did not, and that was proven, then that wasn't quite what we wanted to do. We just wanted to see if in the obese population, are we going to miss folks if we don't basically check for alcohol? And it was significant because the results showed us that 15%, 15.7, so almost 16% of the patients, or approximately 1 in 6 overweight or obese individuals, may well have MET-ALD when they're properly screened, meaning with objective measures. When it was sort of another way to demonstrate the inadequacy of relying on self-report alone. And, you know, it suggests we need to do something different in clinical practice, because I think, and certainly I can look back on my practice and feel the same way. You see people come in your office, you're like, MASLD, you know, lives, breathes, and sleeps. It's easy, you know, slam dunk. And you can be tricked a little bit if you're not sort of really assessing clearly with alcohol, as far as being very specific about quantification and potentially using a very objective measure. And so, again, the findings here we're telling, you know, we're going to miss, you know, a good percentage of patients if we're not really looking deep, and we're going to underestimate the amount of alcohol that is involved in the disease state. So again, here we are. And so we're talking here about her underlying or her risk factors that really gave us the diagnosis in the first place. So we want to take a minute to talk about what, and again, so her PEth test tells us that she probably averages a few more than 2 glasses of wine a day. So what we want to know is, what effect does her alcohol use have on her risk factors? And these were quite interesting, actually. So alcohol consumption can directly raise blood pressure, and patients with MET-ALD may have hypertension that is partially alcohol induced rather than purely metabolic. And so this is a diagnostic challenge, right? This study was showing kind of the effect. It decreases alcohol consumption, decreases blood pressure after 12 hours after consumption, and then goes back up at 13. So again, one, I suppose it really matters when you're making the measurement. But 2, you know, is this an independent risk factor, or is it caused by the alcohol? And so again, this unrecognition, you know, am I taking this hypertension on the face of it as classic hypertension, or is there some sort of alcohol induced effect? Same thing with the triglycerides. So we know that Ashley's triglycerides were above 150, but this is, you know, that's one of the 5 cardiovascular, cardiometabolic criteria used in MASLD. And, you know, this study shows, you know, the effect on triglycerides after an alcohol bolus. So if you look at the graph on the left, this is basically the measurement of the mean plasma triglycerides after 10 hours after administration of 2 standard drinks or water. And the blue line is the ethanol group, or the ones that got the drinks, and that say it significantly increases the triglyceride levels and over time. So they peak at 6 hours post consumption. So again, is that what's driving the hypertriglyceridemia in our patient? Or is it, really the alcohol, right? And so, again, good questions. So back to Ashley. We have a little bit more information because we do have, certainly we have a PEth. Certainly she meets MASLD criteria. She has, we think, a couple of the risk factors that are required. We know that her FibroScan puts her in an at-risk MASLD level. And again, we now have this piece that's maybe confounding a little, and that would be the PEth that's elevated. So what do we think the diagnosis is for her? Well, I think maybe initially would have probably mostly assumed it was MASH or MASLD. And now it looks like it may well be MASLD with the MET-ALD portion being predominant. So a completely different kind of understanding. So what do we want to do? What are the current treatments? So certainly we know that the cornerstone of MASLD management and treatment is healthy lifestyle and lifestyle modification. There's plenty of evidence now that the Mediterranean diet is a great offer for patients that, and if they're able to follow it, there is a good chance that they can lose some weight. We always want to encourage exercise. And certainly Ashley meets the criteria for resmetirom, which is, the first an FDA-approved treatment for fatty liver or MASLD that we've had, and we've had it for a year now. And so we certainly want to use that resource in this patient because she could very much benefit from improved fibrosis and potentially improved steatosis and potentially reversible of some of the damage. And then recommendations regarding alcohol. Well, first we got to ask, right? And then we have to, know what we're dealing with. So certainly abstinence is going to be our recommendation. But if we've uncovered an alcohol use disorder in Ashley, then we have more work to do. And I think the community now understands that when we're dealing with patients who have alcohol use disorders, we need to offer them treatment for that disorder. And I think we have largely ignored that piece for a long time, certainly in the hepatology space, but even in primary care. So that becomes a question that we really need to address, that piece of the continuum of this disease, right? We've sort of got two entities now that we can't ignore one or the other. Does she need HCC screening? Absolutely. We know that AASLD recommends HCC screening at F3 with imaging and every 6-month tumor markers. There is some discussion there. I will agree that is not a hard and fast guideline. Most, in my practice and in our institution, F3s do get screened every 6 months for HCC. And so, what are our questions for clinical trials going forward? Well, oops, did I not go forward? There we go. So based on, we want to look at these things now. So I think it's clear that we need to work with objective ways of measurement. So some of these smaller studies did truly prove that there is underreport of alcohol use, so we want to use objective biomarkers that have been clearly vetted and validated, and we want to make that a standard. I think if we try to take as much of the problems with discussing alcohol out of the management so that we can be more comfortable with our patients and avoiding the stigma. And certainly if we standardize our assessment of alcohol use by using an objective measure, it may make it easier because in patient discussions, you'd be talking about a number, and it takes maybe the onus off the personal things, though there's work to be done. Maybe it makes it easier to objectify what we're trying to accomplish. And then we got to consider that there's more than one thing that may be driving this. And again, I think that's what's most compelling today about this talk is there's really it's really easy for us that have been in practice for a while to just go to MASLD as well. You know, everybody has MASLD. If they have the risk factors, they've got it. But we need to absolutely make sure that we're not ignoring part of the problem. And then if we're really dealing with something that is not there, right? If there is not an actual hypertensive disease or cholesterol problem in the patient, then we sort of have to reassess how we're managing everything. And then we need to, like I said, we need to understand if those risk factors are caused by her alcohol, say her hypertension is impacted by her alcohol use as well as her triglycerides. If we check her out, 6 months into not having alcohol or being abstinent, do those disappear? And so today I'm hoping that you'll recognize that the definition of MET-ALD is the alcohol intake beyond the 15 to 25 drinks for females. I think, no, it's 10 to 25 in females and 15 to 30 per week for men, respectively, really puts you in a MET-ALD diagnostic classification. And clinical criteria as they stand could underestimate MET-ALD, and we saw in a couple studies it really did by a significant percentage, and also certainly straight alcoholic liver disease. Maybe some of these patients who have risk factors may not have the MASLD diagnosis. Past the alcohol biomarkers can really be helpful. And again, we need to relook at the metabolic dysfunction things if we're diagnosing those based on cardiometabolic problems alone and not taking into account the amount of alcohol. And then we just need a better way to objectify our talking to patients about alcohol, destigmatize that like we've tried so hard to do, and renaming the new nomenclature takes the alcohol out of it. But if we're talking alcohol liver disease, we really need to look at very objective criteria, and also, going across cultural and socioeconomic lines with our research. That's it for there. So please come go to the GHAPP MASLD MASH Community Network for additional disease state education. We have a bunch of talks. They're nice, they're quick, different speakers, find them very helpful. And then Resdivra webcast also is available. So if you need to learn a little bit more about treatment of MASLD, there's great resources there. And if you don't mind or have a moment, if you could scan our code to complete a survey and just share your thoughts on what I did today, and we would love your feedback on any aspect of what we're trying to do here at the network. And I would be happy to entertain questions if any of you have them.